Okay, so welcome everybody to our webinar. Today is January 24th. Uh, our topic today is dysrhythmias and anticoagulants. All right, so let's start with the first slides. Here we are trying to go to the point straight and what is needed for NCLEX course exam. So we have arrhythmias. The arrhythmias, as definition, uh, is any rhythm of the pulse or the heart that is below 60 or above 100. So could be bradycardias, could be tachycardias. Those are already considered out of the normal rhythm. So we have bradycardias, and what we are going to focus mostly in this lecture webinar is about tachycardias, and we have the supraventricular tachycardias and the ventricular tachycardias. Tachycardias, tachy means faster, right? So more than 100. Anything that is over 100. Supraventricular and ventricular. So these tachycardias has an origin. This origin, it could be in the ventricles, it could be in the ventricles, or it could be above the ventricles, that is in the area of the atriums. The supraventricular is subdivided, and this is the most common, the atrial fibrillation, and we have the atrial flutter, Okay, so talking about these guys, we will know that the most common of all, and I want to have this picture, the most common of all is going to be the atrial fibrillation. In the United States in 2016, we have 2.2 million people who are being diagnosed with atrial fibrillation. Some people doesn't know that they have atrial fibrillation, just some occasional EKG, they are going to discover they have atrial fibrillation. But this is the most common, is about 2.2 million. And the most common group of population is more older you are, the most actually can develop this problem. So atrial over 60, more in males and more in white people. The causes of atrial fibrillation, just to be short here, is going to be, for example, coronary artery disease, for atrial flutter, coronary artery disease. For tachycardia, BTAC is going to be coronary artery disease, and fibrillation the same. Here, the difference between atrial and ventricular tachycardia fibrillation, that mostly the ventricular tachycardia fibrillation can happen after a previous myocardial infarction. So you can live with this, you can mostly die with this. So mostly sudden deaths, 300,000 sudden deaths in the United States every year is because of this ventricular BTAC or BFib. All right, so let's talk about, we are not going to talk about the anatomy as because this is something that we already understood, but anyhow, I'm going to just be very short here. We have the SA node, if you see the SA node, is the sinoatrial node, are going to communicate with the anterior-posterior bundles to the atrioventricular node. The atrioventricular node go to the bundle of His, you see the bundle of His, and they go to the Purkinje fibers. That all of these are going to depolarize, means produce electrical impulses that make the contraction of the heart. So if I'm going to rescue this picture, because if you have, for example, some atrial fibrillation or atrial flutter, there's some ectopic areas in the atrium. This is the atrium, another atrium. So if this is not working for some reason, there are going to be some other areas that are automatically, they are going to start depolarizing. So that's why you have this arrhythmia of the atriums. Now, if you can tell me that you have the atrial contraction, and the atrial contraction are going to pass the electrical impulses to the AV node, So is you can think that for every electrical impulse that is going into the atrioventricular node are going to go and produce some ventricular contraction. So that means if you have, for example, 150 or 100 or 200 beats per minute in the atrium, not necessarily are going to be 200 beats per minute in the ventricle. Why? Because the atrioventricular are going to select, are going to filtrate, are going to delay some of the stimulus coming from the SA node, and they are going to actually not necessarily be the same beats per minute in the atriums compared to the ventricles. All right, so here we have, and let's talk about our pharmacology now. We have antiarrhythmics. So the main and general side effects that we need to observe is, number one, is orthostatic hypotension. Orthostatic hypotension. Obviously, they are going to decrease the heart rate, right? And the heart rate is necessary for the cardiac output, right? So cardiac output is volume multiplied by the heart rate. If the heart rate go down, cardiac output go down, so that means the blood pressure go down. So safety precautions for that. Orthostatic hypotension. We have urinary retention. Urinary retention. You can have bradycardia and lightheadedness. So but the most common and the most important is orthostatic hypotension. All right, so here we have our scheme about the depolarization and repolarization of the antiarrhythmics. We are going to skip that. Why? Because we are going to apply at the time we are explaining the classification. All right, so we have the supraventricular supraventricular arrhythmias, or dysrhythmias. Dysrhythmias is the same to say arrhythmias. They are going to originate above the bundle of His. So we already know our anatomy. Ventricular develop below the bundle of His. Okay, all right. So we start with atrial fibrillation. The atrial fibrillation is what we just mentioned. So if you can see here, A means the atrial contraction. Atrial contraction is going to be this high in the atrial fibrillation, right? But not all contraction are going to direct electrical impulses to the ventricle. Why? Because the A B nodes that are in between, so the pacemaker or sinusal node, they need to pass to the AB, and the AB is going to not allow all the stimulus coming from the atrium passing to the ventricles. So that's why the ventricles can be slow or rapid. So atrial fibrillation. So one thing that I would like you to remember is that we need to check the apical radial pulse or pulse deficit. Apical radial pulse is you need to use two people, two nurses. They are going to check, first of all, the fifth intercostal space at the level of below the nipple. That is where it's the apex of the heart. If you can make a little bit bending to forward or go to left lateral decubitus, that is going to make the tip of the heart getting closer to the thorax, and when you're listening with the stethoscope, it's going to be easier. Now you have another person who is going to take the radial pulse, and you need both. They need to agree at what moment you're going to start using a watch. So, for example, we start at 12, we start at 6 or at 3, and everybody's counting. And if you have some deficit pulse, what is a deficit pulse? Supposedly, normally, if you have 80 heartbeats listening by the stethoscope, you need to have 80 pulses in the radial pulse. But sometimes that do not happen. There is a variation that it could be considered normal. Everything that is between 60 or 200, that is going to be the normal. So it can be a 20 difference that's considered normal. Why? Because it's the normal heart rate. But if you have a difference more than that, for example, the radial is going to be less than much less than the apical. That means that this deficit of pulse means you have atrial fibrillation. So that is the way how we actually find out the atrial fibrillation. All right, so here we have, let's keep going with the atrial flutter. Atrial flutter is not as common as the atrial fibrillation. Atrial flutter is about 10% of all the supraventricular tachycardia. So atrial fibrillation is the only one. It's not the only one. There are many more, but it's the most common. And from all the supraventricular are going to be the atrial flutter. And if you see here, the P waves. The P waves are very actually erratical, very up and down, up and down. You cannot define very well the P wave here. But look at this, what happened with the flutter. The flutter, they have a big P waves, P waves that are going to be in between this range. Sorry, it's 220 BPM. It's not 2000. It's 220 beats per minute up to 430 beats per minute. And the ventricle is about less than 300. Okay, so talking about the ventricular tachycardia and the ventricular fibrillation, this is very important to know, because those are the ones that are going to do, they're going to produce sudden death. Sudden death. Okay, let me take out this. Okay, so we have the BFib and the BTAC. Okay, so if you see this arrow is telling you that you can start with BTAC and then you can end into BFib. So that is any of these cases. This or this can lead into sudden death. Okay, but the most dangerous of all is going to be the ventricular fibrillation. Ventricular fibrillation. All right, so let's keep going. All right, so let's go talking about the classification. We have classification 1, 2, 3, 4, and 5. If we remember our depolarization, repolarization, the beginning of the depolarization is the entry of sodium. So that means that the channels of sodium are open and getting into the cell in big amounts, and that is going to lead then the entry of calcium for ATP transportation. That is not a purpose of this class. But they are going to continue, they are going to finish the contraction with the entry of calcium. And they are going to start the relaxation with the entry of potassium and chlorine. Okay, so let's talk about the classification 1. And the classification 1 is related to sodium. That is the first thing that occurs at the moment of the depolarization in the cell, cardiac cell. All right, so one of the things is that they're going to produce risk for hyperkalemia. The entry of potassium lead into the exit of potassium in the extracellular. So they can lead into hyperkalemia. Remember, hyperkalemia, signs and symptoms, weakness. They're going to have arrhythmias, right? And lower extremities cramps. So we have agents 1A, 1B, and 1C. So all of them, the three of them are going to be having the blockage of sodium. So normally sodium enter into the cell, but what is doing class 2 is to close those door opens that allow the sodium enter into the cell. So we are closing the doors in the cell in order not to allow the sodium enter. Okay, so then we have the beta 2. Beta 2 is class 2. Beta is the second letter of the alphabet. Is beta class 2. We have class 3. We have the potassium. Potassium channels are going to be blocked. We have class 4, the calcium, that is the calcium channel blockers. We're going to talk about that. And the mechanism of action of some of the class 5 are going to be unknown. So I want just to be you familiar with this. So this classification was made like already 40 years ago, and the guy name was Singh Bahun Williams classification. Okay. All right. So let's keep going. So nursing considerations. So first of all, what you need to do, your vital signs, assess your cardiac rhythm. Okay. And when you are reading AKG, and yes, I'm telling you ahead of time, you besides to know how to take the AKG, at the minimum you need to know how to what is the frequency according to that AKG. We are going to see that in class. If somebody can remind me, it's going to be very simple. Okay, so that is about. So we have another nursing considerations. The patient, antiarrhythmics. Also, the patient is not in the medical field. They don't know anything about antiarrhythmics. So there you need to consider always patient deficit of knowledge. So always that is your intervention, that you're going to educate the patient, right? All right, so irregular pulse rates, they are going to be, they need to be reported. Any abnormal or irregular pulse, okay, so the first thing I will see, I will think about is, first of all, how the patient feels. Second, I will check the EKG, the lab tests, right? So especially the electrolytes, potassium, right? All right, so systolic pressure, SP, normal variance can be between 5 to 10. And if there is more than 10 millimeters of mercury, you need to report it because it's hypertension. Hypertension, listen, hypertension can be a cause of atrial fibrillation, atrial flutter. Okay, it can make worse, for example, angina. They can lead into arrhythmias. So actually, the blood pressures need to be followed very close to. All right, so all medications, if you take, for example, any medication, you can take it with food. If you have GI distress, in that case, happen, for example, in the beta blockers, we are going to see in some anticoagulants, they are going to produce this problem. Big letters here, the pro-dysrhythmic effect. Pro-dysrhythmic effect. This rhythmic effect is that many antiarrhythmics can lead into other arrhythmias or new arrhythmias. These arrhythmias or arrhythmias are the same. So that is how every medication, you need to always be assess the patient very closely. Okay, so another thing that we need to remember is the 6 cardinal signs of cardiovascular is the CDF, EF, palpitations and syncope, chest pain, dyspnea, edema, fatigue, palpitation, syncope. Syncope, we already know that is the loss of consciousness, fainting, in other words. Fainting, in other words, okay? All right, so let's start with class 1. The class 1, we have the disoporamide, the quinidine, and the procainamide, okay? So these what they are going to do is to block the fast channels of sodium. So there are channels in the membrane of the cell that are going to allow the fast entry of the sodium, and some others in the slow entry, another channels that are going to enter the sodium slowly. So this class 1 is going to block these receptors who allowed the sodium enter very fast. Okay, so and that is they are going to block the sodium channel blockers. So what is the main side effect? So remember the name, please. Is we have the disopiramide, quinidine, and procainamide. We was talking in class about our mnemonic, the double quarter pounder. So D, disopiramide, quinidine, and procainamide is P. Okay, so we will see that the most common class 1A will be diarrhea. Diarrhea. Another important thing that I want you to recall always is the irreversible SLE. SLE means that systemic lupus erythematosus. So those are going to give signs and symptoms of lupus, okay? And they are going to be reversible. Remember, in all antiarrhythmics, they can lead into hypotension. Why? Because your heart rate is going down, cardiac output go down, and then the blood pressure go down. So it's a consequence one of the other. Bradycardia heart rate is going down. So you need to be careful to check the heart rate not be less than 60. Okay, so here we have the prolonged QT. That is another that is going to be an indicator that you are having too much reaching toxic levels of antiarrhythmics. So QT is here where it starts the arrow and ends in the T. So prolongation of the QT. You don't need to know the values, but when they are getting prolonged, they are going to have a reactive tachycardia. So that's what we don't want to have. All right, so class 1A, so the double quarter pounder, so that is about, so let's keep going. Oh, what is this? Just a moment. Sorry, I cannot see how I can modify this. Sorry, I'm trying to change my mouse. It's not working. No, not now, please. Okay, so I get rid of that. All right, so we have the synchosism, and this is the when you use the quinidine. Quinidine, this is used for malaria. They have some anticholinergic effects too. Okay, they can be used as anti-inflammatory, so they have many uses. But when this quinidine, the quinidine is mostly used for atrial fibrillation. This atrial fibrillation, when they use the quinidine, they are going to use together with digoxin. What is important for NCLEX is the side effects of how to recognize the intoxication by quinidine. The intoxication by quinidine, what is going to be is the diarrhea, tinnitus, and blurred vision. So very important to remember that. All right, so we have the lidocaine. Lidocaine is again 1B. Lidocaine is 1B. 1B is a sodium channel blocker. They are going to block the intermediate. There is receptor who allow the sodium enter into the cell. Very rapid, intermediate, and very slow. So in this case, they are going to block those receptors who are having allow intermediate speed to enter the sodium into the cell. Period. So now, one thing that we need to remember is that lidocaine. Lidocaine is very common to use, and they are going to be used for some post MI, so post myocardial infarction, because increase the survival of the patients, and this is the less toxic of all the antiarrhythmics. Okay, lidocaine is the less toxic of all the antiarrhythmics. The therapeutic levels will be 1 to 5 milligrams per liter. Okay, therapeutic level. So always you need to assess your the levels of lidocaine by lab test. Okay. All right. So one thing here, the lidocaine is metabolized by the liver. When the liver is damaged, you need to decrease the dosage of lidocaine. Otherwise, it's going to reach the lidocaine going to reach toxic levels. So lidocaine do not come in oral form. It can be in IV or intramuscular, but they are not going to be in PO because they are going to be deactivated with a gastric acid. Okay, so liver is important to remember. Liver, lidocaine, lidocaine. So that is the nursing consideration. So be careful. So we need to decrease the lidocaine in cases of the liver is not working properly. All right, so continue with the lidocaine. So we're talking about toxic levels, right? So in the toxic levels and lidocaine is going to be the respiratory depression. So that's why we learn here about the therapeutic level. The therapeutic level is 1 to 5 milligrams per liter. So if you reach toxic levels, they are going to lead into respiratory depression. Even though lidocaine is less toxic than the rest of the antiarrhythmics, but still this precaution. Seizures and convulsions, okay? So when the lidocaine reaches more than 5 milligrams per liter. So respiratory depression and seizures, so very bad for lidocaine, right? So the difference between lidocaine and lidocaine plus epinephrine, something we already talked about it. So don't get confused because the lidocaine should be only lidocaine alone. And that is can tell you that is lidocaine for arrhythmias in the label or preservative free. Preservative free. So that means that they don't have any other element, only just the lidocaine. So if you don't want to give lidocaine with epinephrine, right? Because epinephrine, what it's doing is going to increase the heart rate, and that's what you are trying to control. You're getting worse if you do that. Class 1C, we have the slow transporters of sodium, and 1C is the flecainamide, it's a tambacor or propafenone, and flecainamide is just need to be familiar with the name, how it sounds. And 1C is only used when 1A and 1B are not effective. When 1A and 1B are not effective, are going to be used 1C. That is the flecainide, okay, or tambocor. Please try not to remember or to study what is medication used for what type of arrhythmia, because that is not going to be asked in the test or in NCLEX. So they are going to give you already the diagnosis and they are going to give you medication. So what you need to focus is are in the side effects, okay? Side effects and some interactions. All right, so here we have the 1C is going to block the channels of sodium. So 1A, 1B, and 1C. But there's a difference between them that we just mentioned. So that's why we have A, B, C. In the 1C, it can produce fluid retention. And this fluid retention, you need to be extra careful in 1C. Why? Because a patient who has heart failure, they can actually gain fluid, and mostly this fluid can flow to the lungs, for example, and they can produce some problems on the respiratory system. The weight gain, you already know, 2 pounds more than 2 pounds in 2 days, or 5 pounds in 5 days. They are going to be about the red lights for accumulation of water. So please, 1C, please fluid retention. We have the lows, propanolol, esmolol, metoprolol. Here with the beta blockers, so class 2. So we already jumped from class 1 to class 2. Class 2 is the second letter of the alphabet, beta blocker. And the consideration I want to talk about this here is that we don't use for COPD for actually obvious reasons, right? And the COPD is because, check here, the COPD, excuse me, okay. The COPD is the chronic obstructive pulmonary disease, and the beta blockers, beta 1 blockers, right? It's beta 1 blocker. Beta 1 blocker is going to is not selective beta blocker, so they can produce beta 1 blocker only, no, but they can lead into beta 2 blocker. Beta 2 blocker produce bronchoconstriction. right? Because beta 2 agonists produce bronchodilation, but we are talking about beta blockers, and they can affect, because there is no selective beta blocker, they can affect beta 2, blocking beta 2. So that means bronchoconstriction. So that's why we don't use in COPD. Class 3. In class 3, we have the amiodarona. We have the vitulidate and the dophytilidate. So that is 8, as we said in class. I remember the mnemonic, 8. And the class 3 is going to do what? Prolong the duration of the action potential. What is the action potential? Action potential is the depolarization and the repolarization. So relaxation and contraction. So the time to produce the whole contraction and relaxation, channel block, potassium channel blockers are going to make that this time of depolarization and repolarization be longer, especially the refractory state, that is the repolarization. Okay, so what is the refractory? That means that if you are in the repolarization, means the relaxation, if you send another stimulus, they will not contract because they need to finish first the relaxation. Okay. All right. So they are going to have longer repolarization, and we can say here that is a longer period of relaxation. All right. So we have potassium channel blockers here, class 3. We are going to use for especially for ventricular arrhythmias, class 3. The class 3 is for ventricular arrhythmias. So what they are doing is to use for rapid conversion of these atrial fibrillations and atrial flutters into normal sinus rhythm. So they are going to be used for both. So class 3 is very common to use too. Is the amiodarona. Amiodarona is for ventricular arrhythmias and for atrial arrhythmias too, for both. But this is mostly when you are having life-threatening situations. They are going to use the amiodarona. All right, so amiodarona, one of the interactions that we need to remember, probably it's a little bit early, but definitely I want to mention is the phenytoin. Phenytoin, because when the time talking about phenytoin, we are going to talk about amiodarona. The phenytoin is going to produce is anticonvulsant, and anticonvulsant is the elevation of this is going to elevate the phenytoin levels, and that can lead into toxic levels. All right, so here we have class 3 amiodarona. So again, all the antiarrhythmics can lead into hypotension, right? QT prolongation, as we already mentioned in the previous slides. All right, so we have the blue-gray coloring of skin. They love to ask you this in the NCLEX, and we don't know how is that happen, but they actually can. I have a picture, I guess. Where's the picture? Yeah, there's a picture there. It's a blue-gray coloring of the skin. We have, if you have a potassium channel blockers, okay, so you better start to check your potassium, right? Hypokalemia should be corrected before the administration of the potassium, okay? All right, so here we have, this is the blue color of the face, okay? Blue-gray coloring of the face. Contraindications, so any antiarrhythmic is contraindicated in bradycardia. Amiodarona, photosensitivity, blue-gray skin coloration. Class 4 is the calcium channel blockers. They are going to be the verapamil, the diltiazem is channel calcium blockers. So that is going to prolong the refractory time. So that means that the time for relaxation, contraction relaxation is going to be longer. So because they are blocking the calcium channels. Remember, calcium enters into the cell to produce a contraction. Okay, so let's go to class 5. Class 5, we have two groups, the adenosine and the digoxin. And the adenosine is a substance that is very interesting. Adenosine is part of the ATPs, adenosine triphosphate, right? Remember that? So adenosine can have this activity as antiarrhythmic. But this this medication is having a very short half-life time, so they need to administer an IV in bolus and should be administered rapidly. The problem with this is that they can have a risk and they can produce asystole. So asystole can happen after a few seconds after administration. So you need to be very careful under physician indication how to administer the adenosine. And digoxin. Digoxin, we already talked that one of the mechanism of action is that digoxin is going to compete with the potassium. Right? Okay. So that is about the antiarrhythmics. Let's go over the anticoagulants. Anticoagulants is going to the purpose of anticoagulants. You see the red blood cells with the fibrin here. That is a clot. So a clot is fibrin, red blood cells, and platelets, right? So platelets are hiding somewhere here. So anticoagulants is going to prevent the formation of new clots, period. So anticoagulants are going to just prevent the formation of new clots. All right, so we have two group of medication, the warfarin anticoagulant and the heparin anticoagulant. The warfarin is PO, is the treatment that is given to the patient and it can be monitored every 2-3 weeks with some lab tests. In this case, the PT or INR. PT is the prothrombin time, and INR is the international normalized ratio, right? And the heparin is given in the hospital, in the clinical facilities, is injectable, subcutaneous, and never intramuscular, can be IV, and they are going to be controlled by the APTT, that is the activated partial thromboplastin time. Okay, so that is a start. We have diagnosis tests for hematocrit, hemoglobin. You don't need to know hematocrit or hemoglobin both, because if you have hematocrit, you divide it by 3, that is your hemoglobin. If you have hemoglobin only, you multiply by 3, that is your hematocrit. So it's very simple. We have the PT and the APTT, and those are the ones who are going to tell how is the coagulation state of the patient. The coagulation state of the patient is going to be variable. For example, when you have turbulent flow in some vessels where you have atherosclerosis, that is a risk for formation of thrombus. Example in the coronary arteries. If you have obstruction of the coronary arteries about 80%, that obstruction can lead into delay of the flow of the blood and produce clots and produce a complete blockage. And that leads into angina, myocardial infarction, and death. All right, so let's keep going. So we have the prothrombin time, the PT time, the PT, and the PT is used mostly for remember kept the cow, for Coumadin and warfarin, that is the same. It's controlled by PT, kept the cow, KEPT, right? So the PT is about 12 seconds, is going to be the extrinsic factor or tissue factor. That is some factors. What does it mean in simple words? So you have coagulation factors. How many proteins? 13 proteins. Some proteins are coming from tissue, and some proteins are in the intravascular, or better to say in blood, in the blood. So in the tissue it's called extrinsic. And when these proteins are, some of these proteins are in the blood, that's going to be called intrinsic. The intrinsic and the extrinsic, they come in together to a common pathway that are going to lead into thrombin, and then they go into fibrin. Okay, so the PT time, that is the kept the cow, remember coumadin, warfarin, PT, and compete with the vitamin K. The lab test what we use is the PT or INR, because INR is related to PT, right? So the normal value is 0.8 to 1.1, that is the normal INR. And if this ratio is better to use that only the PTY, because you have two values, two numbers that are going to be assessed. So that's why it's better these two numbers than one in order to. That's why we use mostly INR mostly than PT. Okay, so if you're taking warfarin, of course your blood is more thinner, right? And the warfarin is going to elevate the INR, obviously. And this INR can be considered normal when you have is between 2 to 3. We have the activated partial thromboplastin time, the APTT, that is used for heparin, the heparin, right? The heparin. And that is longer. APTT is about 30 seconds. PT is shorter. PT is shorter, about 12 seconds. All right, so let's keep going. The D-dimer is fibrin degeneration. So when the clot is forming, the body naturally are going to try to degenerate or dissolve the clot. And this D-dimer can be detected in the lab test. This D-dimer present, that means that you have a clot somewhere in your body. If you have, for example, angina and you have some problem or EKG that is telling you have an infarction, and you have positive D-dimer, probably you have a clot. D-dimer is going to be used for DVTs, deep vein thrombosis. So you go to the emergency room, swollen leg, painful, redness, swollen, and you cannot walk, and they take D-dimer, and most likely that is the DVT. They're sending, what they're doing is sending you to the ultrasound just to check the veins, especially the lower extremities, the posterior tibial vein and the femoral vein. All right, and the troponin. Troponin is, if you remember, is part of the proteins of the cells. Troponin is going to be affected when you have a heart attack. The cells are going to release the troponin. So this troponin is very, suggestive that actually the patient is having some myocardial infarction. Of course, troponin, remember, never a lab test make a diagnosis. Ever, never, ever. So a lab test, what it's doing is to confirm the diagnosis of the physician. So you have these troponin levels plus the clinical examination plus the other lab tests plus clinical history all together, and that are going to make that diagnosis. Okay. All right. So here we have a high leafy green vegetables may interfere with the effectiveness of the anticoagulants. They contain vitamin K. Okay, vitamin K. So be careful with that when you're taking anticoagulants. All right, so another herbs or holistic or over-the-counter medication that can limit the anticoagulation effect is going to be these names. Capsicum pepper, I never saw one. Feverfew, I saw garlic, ginger, ginkgo, saintswort, and ginseng. So we was talking about 3 Gs, now we have 4 Gs. Garlic, ginger, ginkgo, and ginseng. Okay? All right. So let's keep going. So aspirin is an NSAID. Is going to do the platelet aggregation inhibition. So it's going to inhibit. So remember the prostaglandins. I'm not going to go on that, but aspirin is going to cut one of these cascade reactions that lead to the platelets to aggregate, to get together. So the NSAID is going to cut that. So there is no platelet aggregation. If you remember, the primary coagulation is the platelet aggregation. That is what is going to be inhibited. If you don't have that, because what is a clot? Clot is red blood cell plus platelet plus fibrin. If one of these three components is not present, that is not a clot. Okay, so aspirin is as you need to remember why we don't talk about ibuprofen or naproxen or diflucam or whatever other medication. Why? Because aspirin is superior for all the rest over all the rest of NSAIDs of all the rest in antiplaquetary activity. The aspirin is the only one who lasts about 7 days. The rest can last hours, a day or 2 days, but the aspirin is the one who can last 7 days. So that's why it's desirable to use less dose, less often, and less side effects, of course. All right, so we have serious side effects. We have enteric-coated aspirin is being taken for 6 to 8 ounces in order to decrease the gastrointestinal upset. Upset means some increase of gastric acid, some cramps, some even nauseous. They can produce this. So in order to prevent that, you need to take with food and water. Enteric coated is, we know from the very beginning, you cannot crush it, you cannot chew it. The reason because it's coated, because they need to dissolve in the more alkaline environment that is in the duodenum. Because if they reach acid in the stomach, they are going to be inactivated. All right, so risk for bleeding increase with aspirin therapy, even low doses, so we can tell where you can, how you can assess patient with bleeding, right? Gums, bruises, etc. All right, so let's talk about the heparin, parin. All these parin are going to be heparin, okay? So dalteparin, enoxaparin, etc. Actions, what they are going to do is the conversion of the prothrombin to thrombin. And for this, they are going to inhibit the conversion of the fibrin of fibrinogen to fibrin. All right, so heparin. So for heparin, we are going to use some specific material like half inch to 5/8 inches needle into and 25 to 28 gauge for subcutaneous heparin injection. Okay, so that means that we use a very 25 28 is very thin needle. Gauge. So we are going to have a very thin gauge. Okay, so this is the length of the needle, and this is the diameter of the needle. All right, so here we have heparin dosage is considered to be the normal therapeutic range if APDT is 1.5 to 2.5 times the control value. So the APDT we're talking about that is about more than 30 seconds, right? So if you have 35 seconds, multiply by 1.5 is or by 2 about 70. That is actually how heparin are going to be considered still normal values. So heparin dosage is considered to be in the normal therapeutic range if the APDT is 1 to 1.5 to 2.5 times the control value. All right, so anticoagulants, in general, side effects are going to be hematuria, bleeding. Hematuria, you will see the Coca-Cola sign when they go to the bathroom, they see the urine with similar as Coca-Cola in water. So that is similar, that is what we call hematuria. Hematuria. Okay, so heparin, we are going to see very important. We have to know the antidote for heparin. This is, if you know this, you are killing one more question for your anklets. Heparin, by sure, 100% is coming. So protamine sulfate. Protamine sulfate is going to be the antidote for what? For heparin. Okay. All right. So this is the sliding sheet here that we have the, for example, we have here the changes of heparin according to the APTT values. Enoxaparin. Enoxaparin is heparin again, and they are going to have some indications for this. Prevent DVTs, subcutaneous and anterolateral abdominal wall. So it's on the sides of the abdomen, not in the center. Peak is going to be very fast, 3 to 4 hours, and they have 24 hours duration. Okay, so the needle need to leave about 10 seconds after injection. Don't make any massage on the area because they can produce bruising. Okay, warfarin again, kept the cow. We have the vitamin K as an antidote for heparin. In the previous, we have the protamine sulfate, heparin protamine sulfate. In the warfarin, we are going to have the vitamin K and fresh frozen plasma. Fresh frozen plasma is actually given when you have toxic levels of warfarin. The dipyridamole is an anticoagulant. This dipyridamole, when they go for long periods of time, is going to produce anti-plaquetary inhibition. So it's going to inhibit the aggregation of the platelets. But if you give it this dipyridamole in very short times and high doses, they can produce vasodilation. We are in the class here of anticoagulation, so this dipyridamole can be used for long periods of time, and that can lead the anti-plaquetary activity. And mostly they are going to be used in patients with cardiac valve replacement. So what is the most common is the mitral valve replacement by rheumatic heart disease. That means that the mitral valve is totally destroyed, so they replace that. In this case, they are going to use the warfarin at home. Remember, when you go home, they don't give you mostly heparin. They give you warfarin, and the dipyridamole. Dipyridamole in long run, low doses, long periods of time, they can produce the anti-plaquetary activity. Okay, so warfarin, we have INR of 2 or 3 for atrial fibrillation. So that is the value. When you go to you have your patient at home, patient go to the doctor to every 2-3 weeks to check the INR. And because the patient is taking 2 or 3 milligrams a day of warfarin, so they will tell you, okay, you can increase 1 to 4 milligrams, or you can decrease to 1.5, and then you come back in 2 weeks, and then they are going to keep monitoring the levels. One thing, heparin can be safely given to a pregnant. Heparin, but warfarin, never. Warfarin, never. Warfarin can be affect and produce bleeding and miscarriage in women at any time. All right, so warfarin, if you know that the patient is receiving warfarin, you don't want to brush their teeth because they can produce bleeding. So what they are doing is rinse mouth with mouthwash instead of brushing teeth, and check for these lesions, petechias. Petechias are tiny red spots on the skin. So those are actually microvascularizations, microvessels are being broken, and that show like small points on red points in any part of the body. All right, heparin and warfarin. Heparin and warfarin, we have the patient is in the hospital and they need to go home. They're going to be dismissed. They're going to be dismissed from the hospital, and he was taking heparin in the hospital, subcutaneous, right? And they need to change to warfarin. So they need to overlap therapy because they need time in order the warfarin take action, full action. In general, the heparin lasts about few hours, like 4 or 6 hours, and the warfarin can last for days, 1 or 2 or 3 days. So that is about. So they need to make the transition. So overlap therapy or heparin and warfarin at least for 5 days. So that means that you are going to decrease bit by bit the heparin dose and increase bit by bit the warfarin dose until it's ready to go home. Okay. All right. Okay, we are going to talk about a few names here. This is the thrombin inhibitor, right? Thrombin inhibitor is the Pradaxa. Likely they are going to give you the name of the commercial and generic name, but you must need to be focused on that generic name. And thrombin inhibitor, what is thrombin inhibitor is going to decrease the formation of thrombin, okay? And at the end, what it's doing is not production of fibrin. Reduce the risk for strokes is a prodrug. The Pradraxa is a prodrug that are going to be used the liver in order to be metabolized, in order to be active. And that means what? That means that if you have liver problem, you need to decrease or change the medication because that is going to lead into toxic levels of the dabigatran or Pradaxa. Again, if you have kidney problems, liver, kidney, liver, kidney functions, because why? Because all medications are being eliminated by the kidneys, right? If you don't want to have excess of thrombin, if the kidney cannot excrete the excess of all the dose of medication in blood. Okay, so thrombin side effects is going to be the bleeding, the most common. We have another one that is a platelet aggregation inhibitor. So when you have platelet aggregation, it's not that simple. We have many receptors, different type of receptors that are going to make the call to make the aggregation of platelets. So physiologically, they found this type of proteins in the membranes and they are going to use this medication. In this case, we have the aciximab, the integralin, okay, the epitifabatide, and the tirofiban are going to be the platelet aggregation inhibitors. Thrombolytics, I call them the drainers of the faucets. Why? Because fibrinolytic, what it's doing is to dissolve completely the clots. We have the streptokinase, the replace, and the tenecteplase. So those are the ones who totally dissolve the thrombi plural, right? It's going to literally digest the fibrin, okay? All right, so if you have, for example, angina, if you have some angina, you have a clot, okay? You have a clot. So they are going to use some vasodilators in order to increase the blood supply to the heart, and they are going to give you fibrinolytic. And this fibrinolytic is going to dissolve the clot, but the main purpose is to dissolve the clot. Is not secondary. Is going to improve the angina. The pain of angina is going to get less and less. Okay, so TPA. The TPA, the last thing I want to talk about that is used for embolic and thrombotic stroke. Embolic, what, for example? pulmonary embolism. Pulmonary embolism. Who can cause pulmonary embolism? Who can cause a pulmonary embolism? It could be a DVT, right? A DVT. They can go to IVC, to the heart, and then to the lungs. It could be, for example, embolus go from caused by fibrillation, by the atrial fibrillation. If you have atrial fibrillation on the right atrium, they can lead into pulmonary edema. Right atrium, pulmonary edema, right? The clot go to the right ventricle, pulmonary artery to the lungs. And if you have this embolus, what is an embolus? In this case, it's a thrombus that is traveling through the blood in the left atrium. They go to the left ventricle, go to the aorta, go to the carotid arteries, internal carotid arteries, go to the brain and produce a stroke. Okay? All right, so that is the use for TPA. And the antidote, we already talked about 3 antidotes in this lecture, so be careful with that. So open eyes, open ears with those names. And the TPA is going to be the isoaminocaproic acid, or the caproic acid. Okay. All right. So I think that is about what is. We are going to do some dynamics in the class next time. The next class is going to be about antibiotics. So I want to know if there are some questions. Everything was okay. I will be happy to hear from you. Let me open the microphones for you. Melu?
You know we never have any. Hey, Dr. G.
You never have what? Oh,
We never have any questions.
you never had any question? Why?
I don't know. You cover everything.
Well, okay. So thank you, David. Thank you, Meli. So thank you for to be here. I will any question, just please just write me on the email or just in class. I really thank you. I appreciate your time and your effort and your interest. I will see you next time. Thank you so much and have a good night.
See you later. Good night.
Meilu, are you there? Meili? Okay. Going to close.